Thank you very much, and I thank the organizers for inviting us, I think, to this beautiful location and also for arranging such brilliant weather. The weather in the Netherlands, at least, has been awful for about 3 months in a row, so I'm really, really happy to be here. Actually, when I was preparing for this lecture, I thought that, okay, we'll do a lecture on content and you'll get that in a minute, but a school is about perhaps more some people with some more experience talking to people who are relatively new in the field. So what have I learned in these sort of 20 years in science? And I'll give you 2 things that are perhaps the sort of meta content of this lecture. This, I think, is quite important, and my talk will be an illustration, I think, of this principle. The other thing is, something that was alluded to yesterday, is this sort of, I think it's a dogma, that cross-sectional studies cannot be used to study causality. And that's actually because I think that in thinking about causal mechanisms, confounding is much more important than temporality. And I'll illustrate that as well. And if you disagree, I'm happy to enter that debate. So if we consider the question of how obesity actually leads to cardiovascular disease, then you probably will say something like, because it causes hypertension, because it causes dyslipidemia, because it causes diabetes, and there may be other mechanisms. All of this is true, and in this very large study, people try to actually quantify these effects. And here is the idea. Here's coronary heart disease, here's stroke. And here you see that obesity is associated with coronary heart disease and with stroke. And if you now adjust for other things like high blood pressure, diabetes and cholesterol, you see that the relative risk decreases. So some of that is explained by these other factors. And if you look at it more quantitatively, you will see that, for example, stroke, to a very important extent, almost 70% of stroke in people with diabetes is actually explained, in people with obesity, is actually explained by high blood pressure. And diabetes adds a little bit to that here. So about 80% of obesity-associated stroke is explained by these 2 risk factors. For coronary heart disease, it's much less, it's about 40%. So there is a lot of unexplained cardiovascular disease, but on the other hand, hypertension and diabetes clearly explain a lot of the obesity-associated cardiovascular disease. And what I'm going to talk about is how this particular pathway, microvascular dysfunction, causes high blood pressure and insulin resistance and downstream type 2 diabetes in obesity. So this is a sort of conventional overview of how obesity, through increases in sympathetic nervous system activity, the renin-angiotensin system activity, and renal sodium retention, actually causes hypertension. And with alterations in adiponectin secretion, causes insulin resistance. All this is well known to you and has been talked about in other lectures in this meeting. But what I'm going to show you is there is something else here going on, and that is that microvascular dysfunction, by which I mean functional or sometimes structural decreases of capillary density, so-called rarefaction, less arteriolar dilation in physiological circumstances, of which insulin is one, less insulin-induced microvascular dilation, collectively microvascular dysfunction is a causal pathway leading to insulin resistance and high blood pressure, and also is influenced by all of these systems. So it's also a pathway linking obesity to these consequences of obesity. It also actually ties into the previous lecture, because one of the determinants of microvascular function has been shown to be birth weight. In healthy babies with variable birth weight that's actually inversely associated with all of these, and in 8-year-old children that's also the case. We've also shown that overnutrition in the first 6 months actually worsens microvascular dysfunction in very young babies. So this might be a pathway also linking the low birth weight story to these outcomes. So I'll take you through this. I'll show you that microvascular dysfunction actually raises blood pressure, that it causes insulin-mediated glucose uptake, impairment in insulin-mediated glucose uptake, so insulin resistance, that obesity actually impairs microvascular function through dysregulation of adipokines, that microvascular dysfunction worsens further in prediabetes and type 2 diabetes, and in fact predicts incident type 2 diabetes. And finally, I'll show you that weight loss can reverse obesity-associated microvascular dysfunction. So I use this cartoon to make the point that most of our circulation is in the microcirculation, about 98%. These are small vessels, capillaries and arterioles. These are the large vessels that we tend to study. We study them because technically we can. Ultrasound and angiography over the last 30 years have enabled us to study large vessels. But most of the circulation is actually microcirculation. And unfortunately, that has been technically very, very difficult to study in humans, and it has only recently become possible to study this in large-scale epidemiology. So we are basically scratching the surface of understanding what the microcirculation is actually doing. From this cast, you can appreciate that there is dense microcirculation here and much less dense microcirculation there. And people actually vary quite substantially in their microvascular structure. Now, from the point of view of blood pressure, it is important to note that peripheral vascular resistance, very important determinant of blood pressure, is actually determined by the microcirculation. And other things being equal, less arterioles and less capillaries, so-called rarefaction, are a determinant of peripheral resistance and therefore of blood pressure. And therefore, if one measures these things, and this, for example, is in skin. Here we measured arteriolar function and endothelium-dependent vasodilation by laser Doppler fluximetry in skin. In healthy, never treated individuals, hypertensive or normotensive, you can actually see an inverse association with systolic blood pressure. And the same is true when you simply count the number of capillaries in somebody's skin with video microscopy. The more capillaries, the lower the blood pressure. From animal experience, it's known that this property of so-called salt sensitivity of blood pressure, which is the increase in blood pressure that some people have, but not all, that some people have when you switch them from a low salt to a high salt diet, is something that is determined by the microcirculation in the kidney. If you have poor microcirculation in the kidney, at least when you're a rat, you will develop salt-sensitive hypertension. So what we looked at is whether these microcirculatory properties that we could measure in skin are also associated with this property of salt sensitivity of blood pressure. So we changed the number of individuals from a low to a high sodium diet and studied blood pressure. And here you can see that first here is the increase in blood pressure with the switch in salt intake. So this is the salt sensitivity of blood pressure. Some people have an increase in blood pressure when switched to a high salt, some people do not. And it goes with the property of being hypertensive. In hypertensive individuals, there are more salt-sensitive hypertensive, but there are some normotensive individuals that are also salt-sensitive in their blood pressure. And as you can see here, microvascular function is a determinant of this property of salt sensitivity, just like in rats, in fact. In the sense that people with poor microcirculation tend to have the highest increase in blood pressure when switched on the high salt diet. And the same is true if you look at capillaries rather than at arterioles. And there's prospective evidence also that what you might expect is actually true, that people with the highest capillary density, this was measured in muscle, tend to have the highest increase in blood pressure over a number of years. The lowest increase in blood pressure over a number of years. So here is the increase in blood pressure, curiously on the x-axis. We didn't do this. This was a Scandinavian study. The axis should be reversed because this is the cause and this is actually the consequence. And that's what the paper talked about. But people who have the highest blood pressure increase are those who have the least capillaries at baseline. And there is other. This is the one thing that has been possible to measure large scale is the microvascular properties, that is the diameters of venules and arterioles in the retina. And here you see something which is normal. You have arterioles here with the white arrow and venules, and they have a ratio that is something normally like this. So if these arterioles get narrower, you have a decrease in AV ratio of arterioles to venules, and this in normotensive individuals is actually quite strong predictor of incident hypertension. This also suggests that microvascular things precede the occurrence of hypertension. And this is an experimental study, which is interesting. People looked at patients with metastatic renal cell carcinoma, which are treated with this sunitinib drug, which is a signaling inhibitor of this pathway. Now, this is an endothelial cell maintenance factor. So if you block this pathway, endothelial cells by and large will become extremely unhappy, and some endothelial cells will die, and that will give you capillary rarefaction, capillary dropout. And some people have that when you give them this drug, and it's quite rapid. As you can see here, people who have the highest change, negative change, the decrease in capillaries, are the people who have the highest increase in blood pressure on this drug. So there's a strong association, I think, between microvascular function and blood pressure. What about insulin-mediated glucose uptake? Now, you know, at first glance you might think, what has microcirculation to do with that? But the thinking here is that you actually need capillaries and arterioles to effectively and efficiently transport glucose and insulin to target tissues, mainly skeletal muscle, to have proper insulin sensitivity. And this is actually true in the sense that people with the worst arteriolar function or capillary density here are those who are least insulin sensitive when measured with a euglycemic hyperinsulinemic clamp. So cross-sectionally there is at least this association. There's another concept here, that is that skeletal muscle has a microcirculation that has two types. That is of two types. There's a nutritive capillary networks that are immediately linked to the underlying skeletal muscle, and that effectively are meant to increase nutrient supply to skeletal muscle, and there are non-nutritive pathways which are mainly thermoregulatory in nature. So what insulin is supposed to do is to selectively dilate these nutritive networks so that insulin and glucose and other nutrients can access the skeletal muscle microcirculation more efficiently. Now in rats it has been shown, as you can see here, this capillary perfusion on the x-axis, and here is glucose uptake on the y-axis. In a control situation there is perfusion and glucose uptake. If one now adds insulin, you get dilation here and also more glucose uptake. If we add a vasoconstrictor that partly inhibits the dilator effect of insulin, you can see that glucose uptake is also increased. It decreased. So the idea behind this experiment is that apparently these vasodilatory effects of insulin are required for its metabolic effects. And this paper, I think, shows that that is truly an existing pathway, at least in rodents. Here, people knocked out the insulin signaling in endothelial cells. I'll get back to how that works a little bit later, but now the endothelial cells cannot respond to insulin. So in essence, you cannot dilate your vessels to insulin. And here they measured microvascular blood volume, which is decreased in the knockout animals. Interstitial insulin levels are also decreased, so insulin has less access to tissues. These animals are insulin resistant by the insulin tolerance test, also by the glucose tolerance test, and here by a euglycemic clamp, they're also insulin resistant. Interestingly, if you take out the skeletal muscle and simply look at the skeletal muscle insulin sensitivity, it's entirely normal, because it was a selective insulin transduction knockout in endothelial cells, not in skeletal muscle cells. So this also shows that you need endothelial effects of insulin to have normal insulin sensitivity. Now in humans, this pathway is likely also to exist. Here we looked at skin capillaries in simply infused insulin, and there's an increase in skin capillary density compared to a control experiment. If we then, on the basal state, and if we then do reactive hyperemia to further increase the number of capillaries exposed, then we see another increase with insulin. So insulin has this property in humans as well. It's also quite a rapid effect. This is insulin given transcutaneously, so not systemically. And for this effect to be physiologically relevant, it needs to be rapid, because we know that the increase in glucose uptake induced by insulin is a very rapid effect. It's there in 30 minutes. So this effect should also be present quite early, and it's actually there in about 15 minutes, as you can see here. So what about insulin signal transduction in endothelium? This has been worked out quite well. There are two pathways. There's the PI3 kinase pathway, which phosphorylates ACT in endothelial cells as well. You then get nitric oxide synthesis and vasodilation. And there's the other pathway, the MAP kinase pathway, with ERK as the first step. But in endothelial cells, you then get endothelin production, a strong vasoconstrictor, and you get vasoconstriction. Now, these pathways actually exist in all tissues where they have been tested. Normally, they're either balanced or the vasodilator pathway predominates. And what happens in obesity, as I'll show you, is that the balance between these pathways is shifted towards the vasoconstrictor pathway. That's what obesity actually does, and that is caused by adipokines. Here we looked at this system in an ex vivo preparation of arterioles, and you can see that in this particular situation, here is insulin in a dose response. There's not much effect of insulin, none in the physiological levels. So in this particular situations, these constrictor and dilator pathways actually cancel each other out. There's perfect balance. And you can sort of show that there is a balance by blocking the constrictor pathway, which we did here. And if you block the constrictor pathway, the endothelium pathway, you see dilation by insulin. And if you then block the dilatory pathway, the dilation is gone. And you can do the reverse experiment. Here's the control again. Here is now the dilator pathway is blocked, so you see constriction by insulin. And if you block the constrictive pathway by an endothelium blocker, the constriction pathway is gone. That's what happens in normal physiology. In obesity, this is shifted towards constriction, as I'm now going to show you. First in humans, here we looked at capillary recruitment in obese women versus lean women, and it's impaired in the basal state, as you can see here. And if you then add insulin, you normally have dilation, which is decreased in obesity. And this very rapid response that I've shown you in lean individuals is entirely gone in obese individuals. It's not limited to severe obesity. Here we looked at MRI measured visceral adipose tissue, and as you can see here in normal weight and slightly overweight individuals, there's actually a graded association in the sense that people with more visceral adipose tissue have least capillaries, and the same is true for truncal fat measured by the trunk extremio skin fold ratio. And if you go back to rats and you try to look how this works molecularly, you can actually see that insulin is a vasoconstrictor because the dilator action is selectively impaired. Here you see that if you give insulin to an obese animal, insulin is now a spontaneous vasoconstrictor. And this may have to do with adipokines. Here we looked at the effect of TNF-alpha in a very small amount, so that itself it had no effect. But if you add that same amount of TNF-alpha to insulin, insulin is now a vasoconstrictor. And I'll show you the molecular pathway in a minute. And you can do the same thing with free fatty acids. If you add free fatty acids, here palmitic acid, to insulin, insulin is now a spontaneous vasoconstrictor. You can do that in humans as well. In an acute experiment, we infused intralipid in lean women. You can see a decrease in capillary recruitment. And the normal effect of insulin is also decreased by infusing intralipid. And you can do the reverse experiment in women. You can give a Sipimox to induce an overnight decrease in free fatty acids in obese women. So if you do that, you get an increase in capillary recruitment in the basal state, and you also get an increase in the effect of insulin acutely. And here is the sort of summary of a lot of molecular pharmacology experiments. You here have the insulin receptor on endothelium linked to the PI3 kinase pathway, dilation here, and to the constrictor pathway with endothelium here and constriction. So what TNF-alpha does is in fact selectively block the dilator pathway here by activating this kinase. What free fatty acids appear to do is more complex. They activate PKC theta isoform. They then block the dilator pathway here, but they also stimulate the constrictor pathway here, and so you get constriction. Angiotensin 2, I will not show you the data, but will in fact also impact on this system, and many other adipokines are also thought to impact on this system at these junctures. So when we worked on all this, we thought, well, all these adipokines are probably coming from visceral adipose tissue, but we noticed that in the lab there is perivascular adipose tissue. And in fact, we now think that some of these signal molecules are not coming from, exclusively coming from visceral adipose tissue, but also from perivascular tissue, as we have hypothesized about 10 years ago. And we then went on, these are quite difficult experiments in obese rats, perivascular fat in the microcirculation is actually increased. As you can see here, you can do very interesting experiments where you can isolate the perivascular adipose tissue and add it to vessels either from a lean rat or an obese rat and do all sorts of things. And here are some of the things we did. And surprisingly, we found that normally perivascular adipose tissue is actually required to give normal insulin-associated dilation. And that has to do with the fact that, I'll show you in a minute, that normal perivascular adipose tissue secretes adiponectin, and adiponectin is responsible for this dilation induced by insulin. In perivascular adipose tissue from obese rats, they do not have this property because they cannot make the adiponectin properly. Here you see that perivascular adipose tissue from obese rats has less adiponectin. If you block the adiponectin in normal rats, you get no response compared to the normal response. If you add adiponectin rather than perivascular adipose tissue, you get the normal response, and adding adiponectin to perivascular adipose tissue from adipose rats, from obese rats, actually restores the response partially, not completely. So apparently a little bit of perivascular adipose tissue is required and normal and produces adiponectin, and that's responsible for this response. If all this is true, you might expect that microvascular dysfunction is not a property of type 2 diabetes. It is a property not only of type 2 diabetes, as it is a property of obesity, and then logically it should be worse in people with prediabetes or impaired glucose metabolism. And that's actually the case. We studied this in the Maastricht study. In Maastricht study is actually, that was my second point of the second slide, is a study of very extensive phenotyping, because what we are trying to look at is all possible mechanisms and all possible confounding issues when studying causality. So here we looked at retinal and skin microvascular function in quite substantial numbers of individuals. That's now technically possible. I will just show you very briefly. This is what we do with the retina. We selected an arteriole, expose it to flicker light, you then get a dilatory response. In the skin, you can expose the skin to heat, and you get a dilatory response. You can do this large scale, apparently, because we did it. And if you then do that and you do OGTTs, you find things like this. In people with type 2 diabetes compared to people with normal glucose tolerance, you have an impairment of these responses. And in people with prediabetes, you already have some impairment both in crude analyses and in adjusted analyses. So here it says that the microvascular dysfunction that you typically see in type 2 diabetes is already present to some extent in people with prediabetes. And you can do this for the state of prediabetes, but you can also look at HbA1c, and as you actually can see, it's a continuous relationship. There is no clear threshold. And that's both true for the retina and the skin. And you can do it with fasting plasma glucose or 2-hour postload glucose, and you find the same signal everywhere. It's a continuous relationship. There is no clear threshold. If all this is true, then microvascular dysfunction should predict incident type 2 diabetes. And although we have no direct evidence for that, there are markers of microvascular dysfunction, such as plasma markers, such as E-selectin or VCAM or formidable factor, and by and large, in non-diabetic people, they do predict incident type 2 diabetes. The same is true in this one study of peripheral vascular reactivity, which to some extent reflects the microcirculation, and the AV ratio in the retina, which is a marker of microvascular structure perhaps, also is associated with incident type 2 diabetes, and the same is true for microalbuminuria, which for many people is a marker of microvascular dysfunction as well. So by these markers, there is some evidence of prediction. Finally, this is reversible. We did this experiment in lean people, compared them to obese individuals who were then randomized to a weight loss program where in about 8 weeks they lost 10 kilos. Here you can see insulin sensitivity, impaired in the obese, stable in the weight stable, improved in the people with weight loss, as you would expect. But now, what now about retinal and microvascular properties? This is the retina. You see a decrease in the abdominally obese men. These were all men, I should have said. You see no change in the pre-randomization obese. Then after weight loss there's some improvement, and in fact the improvement is such that it is now indistinguishable from normal weight men. This is muscle. This is insulin-induced change in microvascular blood volume measured by contrast-enhanced ultrasound. Very difficult technique. Cannot do that large scale, but you can do it in this kind of study. I will not go into the details, but anyway, you get insulin-induced dilation in lean men, not in obese men. In the weight stable obese men, no change, but a big improvement in people who lose weight. And this change in microvascular blood volume with insulin is directly related, is in fact a determinant of the glucose infusion rate, therefore of insulin sensitivity. And even the change in the individuals that had an increase or decrease of the insulin-induced muscle blood volume is associated with the change in insulin sensitivity, suggesting that it may actually be a determinant of the change in insulin sensitivity. So I will leave you with this. This is something we can now actually study and measure in man. That is because it's now technically possible to do so. It wasn't 20 years ago, but it is now. If you do this, you will find that it is a determinant of high blood pressure, of insulin resistance, and of downstream type 2 diabetes. And obesity is a very important driver of that mechanism, of that pathway. That is because of associations of obesity with this kind of signaling pathways, and there may be many more here. It is amenable to intervention by weight loss and probably also by things like NO donors, by AMPK and exercise. I haven't shown you that, but we have done some experiments with that as well, and also with adiponectin. Many of these experiments have been done by people listed here, and I've shown you those on the slides. And perhaps most importantly, I do want to leave you with these messages. Thank you.
If your weight loss program had exercise training. I'm happy you mentioned exercise at the end. I'm just wondering your take on exercise.
I think that exercise is clearly an important determinant of all this, but in this particular weight loss program, we tried as much as possible to exclude exercise by asking individuals to, this was an experimental weight loss program, was designed to study these mechanisms, not for other things. And so we actually asked them to have stable exercise and sedentary behavior. Yeah. We also are studying sedentary behavior by asking people to wear these active pals things. You may have heard of those. You can wear them for a week or so. We find that people on average sit about 9.4 hours per day. Of the 16 hours that they are awake. In diabetic individuals, it's 9.7 hours. So you can actually quantify these things now, and we find that these are important determinants of all these things.
May I just ask, when you say that microvascular function is a target, I think you showed convincing data that it's involved in hypertension as well as insulin resistance. I think the perivascular fat is quite fascinating. You say you need a little bit because probably the beneficial effects of adiponectin. But if it's too much or if it's dysfunctional, you might get into problems. So is there any data about the effect of anti-inflammatory treatments on insulin-induced microvascular recruitment, so that you might, via that, actually target maybe the pro-inflammatory cytokines secreted by perivascular fat and in that way improve microvascular function?
Yes, so you ask about the anti-inflammatory strategies. In these ex vivo models, you can actually show that blocking the TNF-alpha pathway, for example, or IL-6 will improve the insulin-induced vasodilation. In vivo, in humans, this is extremely difficult to study. The whole issue of microvascular, perivascular adipose tissue is extremely difficult to study because you cannot image it. There are no imaging techniques that can study it non-invasively, so what people do is they take out this in your buttocks and then study the perivascular tissue of these arterioles ex vivo. That's about the only thing you can do at the current state of technical affairs. But clearly point 1 here applies.
Yeah, but maybe not to unravel whether it's mediated via perivascular fat, but just in the large. It's a recently developed technique, I understand, but that would be very nice if you could, in just general anti-inflammatory intervention, look at insulin-induced microvascular function.
Yes, there isn't a lot on that yet. No.
Yeah, one last question for this session, Tom.
Thank you very much. Very clear presentation. Again, it becomes clear that one value of international meetings is that you have the opportunity to meet with famous national colleagues. So I'm grateful for that. And I'm happy that you invited us to discuss these statements. And I tend to agree with the second statement, especially with the last part. But my question is, what about mediation? Because you showed very clearly that if you adjust for the confounder, the association reduces. But the same happens if you adjust for mediators. And from your fifth conclusion, your fifth part, you say obesity induces, and then everything was there on the slide. So I think you are studying hypertension as a mediator here, rather than a confounder. So the question is, to what extent do you think hypertension in this story is a confounder, and to what extent could it be a mediator?
In the obesity, hypertension, stroke pathway, it is a mediator to a very large extent. It may be a confounder to some extent. I think you're alluding to an extremely important issue that does require multiple measurements over time of all variables to disentangle. Nevertheless, what many people do not realize is that there are also statistical techniques called multiple mediation analysis that to some extent, if you once you have a physiological model of how you actually think that the pathway works, allow you to test the pathway even in cross-sectional data or in data where you have a before and after measurement. So you have 2 measurements of everything. You can do that, and people actually from the social sciences, interestingly, have developed these statistical techniques to which I think should, and we actually do use them in biomedical sciences, to try and help us disentangle these pathways. Yes.
Thank you.